Yes, Ramya, can we begin
Yeah.
the session?
Yeah.
Fine.
Yes, sir.
Yes,
Yeah.
good evening. Yeah, good evening. Welcome one and all to our 292nd session of Mental Health webinar series. To enlighten, as we have Dr. M. Ramya Mageshwari, who is actually head of the Department of Psychology at Ethiraj College for Women, Chennai. The topic which you have is psychology for exercise behavior. So for these things, I welcome all the sincere participants as well the today's speaker, behalf of Department of Psychology, American College, Madurai, and our head, Dr. Suresh Kumar, as well our co-team member of Mental Health Webinar Series in Madras School of Social Work, Chennai, International Center for Clinical Psychology and Psychotherapy, Germany, M.S. Chalamuthi Institute of Mental Health and Rehabilitation Center, Madurai, Advanced Education and Psychology Research Center, Madurai, as well Psycho-Oncological Association, Turkey. Yes, once again, I welcome I requested Dr. Chandra ma'am to give more intro about our today's speaker, Ms. Ramya. Chandra ma'am, please.
Good evening, sir. Can you hear me?
Yes, I can hear.
Yes, yes.
Good evening, everyone. On behalf of the core team, I'm happy to introduce today's speaker, Dr. M. Ramya Mageshwari, who is currently working as head of the department Psychology, Ethiraj College for Women. She is an alumni of Bharathiar University, Coimbatore, Women's Christian College, Chennai, where she pursued her MSc in Applied Psychology and PhD in Psychology. And she has teaching experiences in Women's Christian College, Chennai, and Sri Kanyaka Parameshwari College of Arts and Science, Chennai. She has published articles in national and international journals, and she has also been the author of book chapters. She has organized seminars, workshops, and training programs. She has given guest lectures in different topics and different institutions. To her contribution in teaching and professional activities, she has been the member in syllabus revision in Tamil Nadu Public Service Commission. She has been a subject expert in Board of Studies at MSSW, Chennai. She has also been engaged in syllabus revision in different colleges. And she has been a member of the academic audit in MSSW. She has carried out counseling services to students. And she has also written lessons to institutes for distance education. With such credential note, we are very happy to have you here, ma'am, and very eager to listen to you on psychology for exercise behavior. Thank you so much for being here. The session is yours now.
Thank you so much, ma'am. Thank you so much for those kind words. I, at the outset, would like to thank all the organizers, the principals, the directors, the heads of the departments, and the other core committee team for having such a wonderful webinar series. And 292 is not a small number. So, and I'm really glad that I am also a part of it. And I profusely thank each one of you for having me in here today evening. Okay, so the topic that I'm going to be handling today is psychology of exercise behavior. So though I'm going to be talking about exercise behavior, I would like to make a disclaimer here that I am not an exercise physiologist. I am not writing prescriptions for people who are recovering from a particular injury, be it a sports injury or coming from a surgery, or I may not. I'm not a part of the obesity clinic trying to give exercise recommendations for people who want to lose weight or anything. But then my interest in this particular topic actually began when I started to understand obesity. And one of the studies that were published in the most esteemed journal, The Lancet, came up with this title called as Obesity is a Treatment-Resistant Disease. So one of the things that struck me when I kind of registered for my PhD was that with so many pounds and dollars of money being pumped into the exercise and fitness industry, why is it that we are calling obesity as a treatment-resistant disease? Okay, and exercise was considered to be an antidote for obesity. And why is that people, knowing very well that exercise can offset some of the adverse debilitating effects of obesity, why is that people are not exercising? So that led me to, work on this field, and therefore I kind of did my PhD in exercise behavior to understand what psychological principles went into explaining exercise behavior. Why is that people were exercising, if they were exercising, were they exercising sufficiently enough? What is the required amount of exercise that is required to offset the debilitating effects of these non-communicable illnesses? Like, for example, now we have like a lesser number of wellness years to our life because we are living longer. We are living like up to 80, 90. But the amount of time that we stay free of illness is very less. Like, we have a lot of people complaining of backaches, low aches, pediatric cancers. So all of this is settling in very early age. And so that was the reason why I kind of ventured into exercise behavior. So, okay. How do I move? Okay. So I just started with physical activity versus exercise. Physical activity, we all know that our body consumes energy even while at rest. So physical activity is considered any activity that is produced by skeletal muscles that actually results in an increase over our resting energy expenditure. So resting energy expenditure generally is different for men and women, and with women having lower resting energy expenditure, which means women have more propensity to gain weight than that of men. And exercise, however, is considered to be a subcategory of physical activity that is more planned, structured, and repetitive bodily movements that was done to improve one or more components of physical fitness. So, so it is not just about health. Exercise was just not about health, but it was also about strength, agility, endurance, flexibility, and all of that. So, it was not, it is just only one subset of what we call as the physical activity. So exercise psychology, basically, psychologists basically started looking at what were the psychological principles that led to people adopting exercise and also maintaining that exercise behavior, because many people start it, but they don't stick to it for a longer period of time. So what were the psychological principles behind people adopting it and maintaining it? And also the psychological consequences of exercise, which all of us, I think, know that there are both physical and psychological effects of exercise, and which means I'm not going to be venturing into it. So my talk today is going to be talking about, what are the psychological factors? What are the psychological principles behind exercise participation? So this is given by the WHO. These are the recommended levels of physical activity. And they have given different levels of physical activity for people aged 5 to 17 and adults aged 18 to 64 years. I think most of us in this group will fall into the second category, 18 to 64 years. They say that, a person should have at least had, for us, I would say that, at least 150 minutes of moderate intensity physical activity, or at least 75 minutes of vigorous intensity physical activity. So they were trying to make a distinction between light, moderate, and vigorous intensity physical activity. Basically meaning, when we do a particular activity, our body consumes oxygen. So depending upon the oxygen consumption that is happening in the body, which is kind of measured in metabolic equivalence, activity is considered to be light, moderate, or vigorous, basically. So anything like folding a laundry or just taking a walk around the office is considered like a very light activity. Anything that is brisk walking, a little bit of slow dancing, okay, is called as moderate intensity activity. And high intensity activities are like, running, doing an athletics, sprinting. So all of these are high intensity activities. So one way to know whether you are actually engaging in a light intensity, moderate intensity, or heavy intensity physical activity is to do something called as a talk test. So in a talk test, when somebody is doing a light intensity physical activity, that person can talk. You can strike a conversation with this person, and then you can understand what the other person is saying. When somebody is doing a physical and moderate intensity physical activity, this person can talk but can't sing. And somebody with a vigorous intensity physical activity can't speak more than a few words because the person will be actually gasping for breath. So that way we know that, how much faster or our heart is pumping and how much of energy is being expended. And they said that for additional health benefits, people will have to be engaging in moderate intensity physical activity of about 300 minutes per week, along with muscle strengthening activities. Muscle strengthening activities are emphasized for all ages because the resting energy expenditure, they tend to derive their energy from muscle mass than from the fat mass. So it's important that we develop muscles and just not, accumulate as much as fat as possible. Okay, this was again the recent study. This was a study which was done in 2012 for Asian Indians, which recommends a total of 60 minutes of physical activity every day in view of high predisposition to all these type 2 diabetes mellitus and hypertension. And that actually included 30 minutes of moderate intensity physical activity, 15 minutes of work-related, and 15 minutes of muscle strengthening exercises. So about 60 minutes every day. Okay, and if it was of moderate intensity, it had more immediate, large, and long time, not only just physical effects, but also emotionally, like, you were feeling good, you were feeling more confident, your mood was better. So all this was documented. So this is basically an activity pyramid, okay, which tells you what are the things that you need to do. What are the things that we need to kind of limit sedentary behaviors. Sedentary behaviors is excessive TV viewing or sitting at your computer for like hours together, because sitting is now considered a new smoking. The amount of the adverse effects of sitting kind of even overcomes the adverse effects of smoking, is what they say. And it gives you what are the things that you need to do 5 times a week, what are the things that you need to do on an everyday basis. Okay, this is for I was told that there are a few students in this group, and this is for all those students who are wanting to do, research in the area of physical activity. And there has to be a need to, we need to kind of measure physical activity. So when we say how much is enough, whether what I do is enough or not. So there has to be a way to monitor the amount of physical activity that we are doing. And this particular picture kind of tells you, like, for example, if you were putting a few group of people in a gym or in a community center and asking them to exercise and directly observing how many times a week they are doing it, then that's direct observation. But you cannot do that with large amount of people. If you have, like, say, a group of handful of people to work on, then probably you can choose the options like direct observation, helping people to observe physical logs or diaries and everything. But if you are looking at a population level survey, then you will have to basically go for recall surveys. And there are international standardized recall surveys that are available for you to take up these questionnaires and to code the activity in terms of frequency, intensity, duration, and to get a total score of the physical activity. So physical activity is kind of defined in terms of what we call as a TACT element. TACT is the target. What kind of activity for how many days in a week and for how many minutes each day. So you give the target and the form of exercise. What is that you're going to, are you going to do yoga? Are you doing strength exercises? Are you doing resistance training? Are you doing weight training? Are you doing cardio, like aerobics kind of Zumba kind of thing? So what is it that you're doing? The context, sometimes in research activities, especially if you're doing something on a population level, context cannot be specified. Okay, so because people tend to do physical activity everywhere, okay, and if they were trying to incorporate that into their daily lives, then it's almost everywhere. So sometimes context is not possible, but it is important that we have a proper target, action, and time defined, and only then we will be able to sufficiently monitor and see whether this physical activity is sufficient for this person. Let's say if this is a person who's trying to, rehabilitate himself from a stroke. So which means you'll have to kind of specify what intensity, what type of exercises will this person need, so that his rehabilitation process is successful. Okay, and therefore what are the things that he need to maintain? So these are things that we need to kind of specify. So when one thing that people did observe was that, okay, when people kind of, there was this, I think this fitness craze of 90s were like just going all over everybody's head. And if you looked at the centerfold of Playboy magazines, or, even the way, people idealized men and women, thin was replacing as a new idol than that of the well-rounded appearance. So people were like, they had to kind of, they were saying, if we were going to emphasize on so much time of physical activity every day with this particular intensity, then it became like a work for people. So it was something that was actually bogging them down and they were not finding it pleasurable. So the new recommendation actually extended the traditional exercise fitness model to a broader physical activity health paradigm. And this paradigm, this recommendation was unique in two important ways. One is that the health benefits of engaging in moderate intensity physical activity was emphasized. So you don't have to go for an intense Zumba wherein you are like sweating yourself out, and then, you drag yourself back to work or you drag yourself back to home and then have no energy to spend with your family or no energy for the other rest of the day. So that's not what people were looking at. We were looking at engaging in moderate intensity physical activity and accumulation of physical activity in intermittent short bouts. If, for example, I can say, see, my office is just 10 minutes closer. So, even if I walk, I'm going to get only 10 minutes work. Why should I walk? I might as well take my bike. Something like that. So they were saying, no, it's not that. Even if you were getting, say, let's say, if you instead of 60 minutes at one whole day, I'm not able to go to the gym. 6:30 to 7:30 is not possible for me because that's when I have to send my children home, to school. Okay, fine. But then you can do 15 minutes in the morning, 15 minutes in the afternoon, and 15 minutes in the evening, and 15 minutes in the night. Is there something like that? Is it possible to kind of accumulate physical activity? So accumulation of physical activity in intermittent short bouts was considered enough. And so these recommendations were based on the growing evidence that the health benefits of physical activity were actually predominantly linked to the total amount of physical activity performed than the specific manner in which each of these were performed. And by doing so, people were more enthusiastic about encompassing physical activity into their daily lives. So now I actually move on to the psychological principles that define exercise behavior. And these were some of the social demographic determinants of exercise, and all of this has some influence on our exercise behavior. Generally, when we are young, we are allowed playtime, which actually kind of comes down when we move up through adolescence and adulthood. But then again, after retirement or sometimes after we hit the middle age, we feel the need to go back to exercising or, involve in a lot more physical activity. And across culture, females are less active than males. And race and ethnicity also has a bearing. Like, for example, there are studies which shows that, Blacks and Hispanic Americans kind of, less exercise less frequently. And in India, the overall prevalence for insufficient physical activity actually has come down. Like, people are little more physically active when compared to what we were like in 2001. 2001 to 2016 statistics shows that, there has been an increasing awareness about the importance of physical activity, and people are now doing it a little more. Socioeconomic factors also play a critical factor in physical activity initiation, but not so much once PA is established. Why? Because PA, like any other personal behavior, can also become a part of a person's habit. So once formed as a habit, okay, or in your socioeconomic backgrounds don't play a role, but then, like for somebody to join a gym or for somebody to allot a time or to go into a physical activity setting, all of this the socioeconomic factors can be as hindrances. Employment, full-time people who are in full-time employment and even those in sedentary occupations, they were more physically active than those who were not working, probably also because of the interaction between psychological and physiological energy levels and other things. So, this is one slide wherein I would like to spend a major time on, because this is what I did for my PhD, and this is one of the health behavior models that has been extensively studied in connection with exercise behavior. This theory is called as a theory of planned behavior. There are several health behavior change models that posit a variety of psychological factors that predict the so-called exercise intention. So if you look at the model here, there is something called as an exercise intention here. This intention is nothing but the readiness to perform a particular behavior. And this readiness, according to the model, is predicted by the attitudes a particular person has on the behavior. And so attitude, all of us know, is are favorable or unfavorable evaluations with respect to the behavior. So if I have a favorable attitude toward exercise, I will exercise. If I don't have a favorable attitude, I will stay away. Basically, as simple as that. Subjective norms are beliefs about what significant people in my life think about the behavior in question. Like, do my parents support me of doing an exercise? To what extent people will support me if I want to join a gym? So these are subjective norms, and perceived behavioral control is somewhat related to self-efficacy, but not self-efficacy. It is the extent to which a person believes that he can control environmental barriers to performing a particular behavior. So it is here that the answer to my question came in. So far, I have been thinking that, exercise, like any personal behavior, is completely under one's volitional control, which is not. Okay, so that is why many people who want to exercise don't exercise. Though you have a very, very high intention to exercise, you still may not initiate exercise because there are a number of barriers. There could be situational barriers, there could be motivational barriers, there could be a lot of environmental barriers that are actually stopping you from engaging in the behavior. So this part of this, the perceived behavioral control, was actually added to this theory, okay, because they kind of understood that if the behavior is completely under volitional control, and if the goal is very realistic, perceived behavioral control alone will predict behavior. It will bypass intention, everything, and it will actually control behavior directly. So that's what people found. So I kind of started looking at what was actually feeding those attitudes, what were feeding the subjective norms, and what was feeding those control beliefs. So I had to list. We did have a focus group discussion, and we kind of elicited beliefs, behavioral, normative, and control beliefs with respect to exercising. And we asked, okay, so what are behavioral beliefs? Behavioral beliefs are like, if I engage in a particular behavior, what will be the outcome related to that particular behavior? Okay, so because the human psyche is made that way, that if at all we are asked to do something, the question that we would ask is, what is it in it for me? Okay, why should I even do it? Okay, so that was your behavioral beliefs. So some people said, exercising 30 minutes, engaging in moderate intensity physical activity for 30 minutes every day for 5 times a week would actually result in weight loss. For some people, it would just improve my mood. For some people, it would just boost my self-confidence. Okay, so there were different beliefs that were attached to and these beliefs were actually feeding on to the attitudes. That was what I found. And it is not enough if these people have beliefs, but they also will have to value those beliefs. For example, I believe that exercising so much will lead to weight loss. Okay, now the next question is, how much do I value weight loss? Okay, so that both beliefs, okay, and the value that is attached to those beliefs vary from one population to another population. I was working on obese adolescent girls, and I found one of the beliefs that they valued the most was exercise being associated with inch loss, that was giving them a good body shape. Because at some point in time, they had lost hopes about losing weight, at least substantial amount of weight, and maintaining it. So they were looking at inch loss, and that was one of those beliefs. So I said, they said it would reshape my body. They said exercising so much would reshape my body, and I value reshaping my body so much. So that was a very significant finding. But this may not be the same with another target population. So ascertaining beliefs that are relevant to particular population, particular age group is very relevant in even developing exercise interventions for people. And normative beliefs, again, significant people, like for example, my mother could have a major influence of me. That is one aspect. And is my mother exercising as well will also have another major impact on me. Okay, so my mother saying you exercise, but she doesn't exercise, she's engaging in sedentary behavior, will send conflicting findings. But if she says it and she does it, then it has more effect on the subjective norm. Control beliefs, beliefs to the extent to which I can control barriers that are related to exercise participation. Anything from personal barriers, situational barriers were all listed. People were talking about laziness, boredom, pain, fatigue, exhaustion, their own current weight itself, their health conditions, as all of them affecting their control beliefs. So here, so according to this model, intention is a readiness to engage in a particular behavior, and intention is considered to be an immediate antecedent of behavior. So it was, according to this model, it was assumed that, getting people to the stage of intention was enough, because once you get them to the stage of intention, behavior will automatically occur. But then the later only people understood that not everybody with a high intention for behavior will actually go into exercising. There are again lot of this gap, intention behavior gap in the exercise literature is like a black box. It has a number of, again, socio-psychological variables that mediate the relationship between intention and behavior. So there are several models that have actually cited post-intentional factors that could bridge the gap between intention and behavior. So these are some of the research studies on attitudes and social influences. I just put them because, it would be very empirical, and it would be like, reasons for why we need to place emphasis on the attitudes and social influences on physical activity, intention, and behavior. Most of the time, people had negative attitudes, and it was these negative attitudes that strongly predicted exercise behavior than positive attitudes. More than they like exercise, they should not dislike it. Okay, if they dislike it, okay, they will not engage in it. And for many people, it was, if exercise was a part of a GP prescription, general practitioner prescribed, okay, they say you are showing insulin resistance, now you will have to start exercising. They put them on a metformin and then give them exercise prescription, then people will follow it. And again, social influence, people are likely to be physically active in the company of friends, peers, and other things. Here also, I told you how social support and perceived behavioral control. So it says social support influences perceived behavioral control. I feel in control of my ability to exercise when my father or my mother supports me, which in turn makes me to have a favorable intention to exercise and also stick to that exercise. And the more cohesive I am in, like, for example, like here in this group, it's always nice when we have a group of people to do things together. And the fact that, we are all in it together can actually increase favorable attitude towards exercise and its adherence. Okay, so here again, for anybody to kind of develop exercise intervention, we need to understand what factors facilitate intention and behavior and what factors hinder behavior. So I have put in something like, these are all studies, standardized and published studies, which again tells you how much each of these factors are important. Like, for example, the person's perceived body weight, desire for fun and excitement, need to enhance physical appearance, higher self-efficacy, better functional status, greater use of self-management strategies, opportunities for interscholastic and intramural sports programs, and certain personality traits as well. Certain personality traits, such as neuroticism, extroversion, and conscientiousness is linked to a physical activity. Exercise motives. So generally, there is a subset of population, like, for example, I think it's just not even with adolescents, even with adults, especially those with chronic health conditions. Okay, if you make it as a part of the treatment, they are made to feel that if not this, then, your health will be at risk and you may not live longer. If that is the kind of connection that they are making, then people don't like it. But if they like it as a means of, making them feel much more active, okay, it kind of enables them to do the kind of activities they had always wanted to do, then people are more interested in exercising. Built environment also strengthens the relationship between the perceived behavioral control and behavior, because there are now, we see multi-storied buildings with no sidewalks. Okay, every, if you enter a multi-storied apartment in Chennai, Okay, all the space outside the apartment is a parking lot. Okay, and then there is like nothing. There is a lift, even if the person will have to go up to his home, and there is absolutely nothing. There is a, but now I think, Greater Chennai Corporation is also trying to have more parks and more facilities for exercise or physical activity. But in the absence of that, built environment can be one of the hindrance. If there are built environments are helping them to exercise, then definitely yes. Exercise self-regulation, yes. Instead of somebody kind of nagging me, if it comes from within me, then I will do it. That is what the study basically says. Barriers to exercise participation. Again, here again, this particular picture shows you the different domains, under which these barriers can be clubbed. Physical barriers such as pain and fatigue, psychological barriers such as lack of motivation and fear of pain. And see, even in my study, I found that fear of having an injury was one of the barriers for obese people to exercise, because for them, if with their weight, if they sprain and their ankles, they are not going to be able to get up. Okay, and that can increase the chances of them becoming more overweight. So that was one of the cognitions that were associated with not engaging in physical activity. Social support, lack of social support system, the cost that is associated with the gym, like, sometimes you have to pay 10,000 or 12,000, which is not affordable for all the people, and not having safe places. Let's say, your house is located near a bar or a pub, wherein, you it's not just safe for you to venture out. Then again, problems will be there. So each, again, like I said, there are each population will have a certain set of beliefs, and each population will also have certain specific barriers. Like, for example, a person with a heart illness will have a different set of barriers. A person with some other condition will have a different set of barriers. And within each group, those with a high intention to exercise and those with a low intention to exercise will have a different set of barriers. And those with a high intention will report fewer barriers, whereas those with a low intention will report more barriers to exercise. So these are the other barriers, like time. Time is one thing. Like, for example, it's a college student, her academic schedule coming in her way. If it's a family woman, her family and social commitments coming in her way. So time is definitely a problem. Physical exertion is another problem, because many people, especially adolescent girls, they tell us that, they don't look like, they don't like looking sweaty. Okay, like, their hair messed up. They don't like their physical appearance that way, so they don't do it. Absence of companion or a personal trainer. Weight related teasing, how the body image, like, for example, if I do like a Zumba with another set of people who are not so obese as me, like, what will people think of me? Okay, so weight related teasing, lack of self discipline, and negative attributions. Many people who are overweight don't even believe that they are overweight. They may say, okay, probably, it is genetically, endowed in me, so I can't really do anything about it. So therefore, even indulging in an exercise is not going to help me. Such kind of negative attributions will also have an impact on exercise participation. So again, I have just pulled in two other models of health behavior change to look at the post-intentional factors. As I told you in the previous slides, the gap between intention and behavior is like a black box, and there are a number of psychological variables that can mediate the relationship between the two or moderate the relationship between the two. Not everybody with an intention will actually go in for the behavior. So, what another model called as the health action process model said was that they were differentiating people who were in the pre-intentional phase as well as in the post-intentional phase. And they believe that, action self-efficacy, perception of risk from inaction, all of that were, determinant of the pre-intentional phase. Whereas once they initiate it, then their confidence in the ability to cope with the barriers, a proper action plan with the detailed instructions of what to do, when to do, where to do, and how to handle the barriers if at all they arise. All these will help them to kind of maintain the behavior that was initiated. And this was one thing, development of implementation intentions. So instead of saying I intend to do, Okay, like I had asked this question in my research. I said, okay, now that you intend to do, when would you start? Okay, so then they had given them 4 options. I had given them options like from tomorrow, within next week, within next month, uncertain. I don't know. Okay, so those with intentions also, that I could find that there were a lot of people who said, I don't know when I will begin. There is an intention, but there is a clear idea that they don't know where to begin. So development of implementation intentions. Okay, if I have committed, then what? So implementation intentions are very important. And this is also another slide. I think I have put it here. Motivation, everything is in the pre-intentional phase. And once it comes to action, you need to set proper goals, planning, coping resources will have to be enlisted. And then something has to become a behavior. Okay, it has to be a behavior. And then you can also enlist, as a psychologist working in the exercise field, they can also enlist the support from governments and other policymakers to restructure environments, to create more opportunities for access to exercise facilities, to reduce the costs associated with the exercise facilities, community intervention programs where, yoga and other things are being taught in parks for no cost, either with a personal trainer or without a personal trainer. Programs that incentivize physical activity. Like, for example, if you kind of join this physical activity, and if you finish this particular set goal, then you will be paid so much. Especially with the high-risk groups, they can plan such activities. And more than intention strength, intention stability. I want to do it is always I want to do it. It's not like, yeah, I wanted to do it sometime back, but not now. So that kind of an attitude will also not result in, intention translation into behavior. And past behavior, like for example, those with an intention and also had exercised in the past are more likely to exercise now than somebody who has not exercised in the past, but with an intention to exercise. So I'm almost coming close to the end of it. Exercise interventions. So for developing exercise interventions, this is another model, health behavior model. The one you see on the right is from a model called as a trans-theoretical model of change, which basically divides people into 5 different distinct stages. According to the model says that people move through these planning stages from pre-contemplation, that is when I don't think of a health behavior change at all, to contemplation, to action, to maintenance, and then also be informed about the relapse and know what to do when there is a relapse. So at each stage, they have identified the goal and they have identified intervention options here. So you see that, for example, to maintain regular activity, you have to provide continued support and feedback. This feedback can be given in the form of an informational booklet, or it can be through a phone call, or it can be through some ways of monitoring, or you can do a contingency contracting. You can tell them where, when something will happen, and you also establish cues for doing it and punishment for not doing it, feedback, self-monitoring, having diaries. So all motivational interviewing, I think, is one of those newest techniques that we are going to be using, and to look at ambivalences that are associated with exercise behavior, generate the change talk within the person so as to be able to start exercising. And implementation options. So this is the basic idea of exercise interventions. How people do it and what theoretical framework they will use is up to the target population that they will have in question, and also about how they would want the results to be like. So these are the final takeaways from the talk today. The amount rather than the form, frequency, and intensity of exercise needs emphasis. Many may benefit from short bouts of lesser intensity physical activity, which doesn't allow them to associate PA with negative outcomes. So it's very important that when we design an activity also, it should be more varied, it should be more fun-filled. So I've just to avoid monotony and boredom, and it should not be of anything that is of vigorous intensity. The focus should not be on weight loss. The focus should not be on something like but it is something like something that incorporates into the person's belief system as something that is a part of the person's routine. And focus may be on activities done on a non-competitive basis, such as because anything that is done on competitive basis will actually lower the perceived self-efficacy. Like, for example, if you're trying to put somebody with a health condition without a health condition, like let's say somebody with problems with, like for example, thyroid issues or something like that, and they are already having some lethargy and other things, people who are obese or people who have already had a heart surgery, and then, when you say that, you'll have to finish this because the others have finished it, then it will perceive their it will lower their self-efficacy and avoidance. Finally, it is removing barriers is important. Since body image has bearing on exercise participation, activities that require wearing attires that are beginning of body structure, like swimming. For example, girls in our culture, some families may not want to wear swimming attires. For certain groups, it will be the community-based classes without personal trainer. And for students who are wanting to study exercise behavior, there is a paucity of theory-based intervention models in India. And the more we work on theory-based interventions, most of the exercise activities or lunchtime physical activities or something that happens in schools in terms of sports participation and other things, because otherwise physical activity is not taking place. Work sites or, or industries are not giving options for physical activity unless it is a part of their work itself. So that is there. So if you have a theory-based intervention, it is also we can kind of identify the goal. The implementation content can be identified, whether it is access management that you need to work with this particular industry, or whether it is barrier management that you need to work with this industry, or whether you're going to be working on relapse prevention with this particular group. So you will have the content for intervention will be clear when you have a theory-based intervention model. And a lot of apps are there now with helps to establish goals and monitor the levels of physical activity, which we can use it to our avail. Pedometers, accelerometers, all of these are very easy, and a lot of apps are now coming in, and these can be tools for self-monitoring and, kind of, so that we can, increase or decrease the physical activity based on what we are already doing. Thank you. So I am done with my presentation.
Thank you, ma'am. And Veera sir, are you there?
Sorry, I think I exceeded time.
No, it's time is there.
Okay.
For me, it's a new learning. As I said, for many of the webinar sessions I am participating here, new learning, and a person has 3 years time for research work and giving it in 40 minutes. It's I can say snapshots of it, and I think we are getting that Amildam Solvan in Tamil. What we are getting, that extract of what you have done in the last 3 years. Thank you so much for a wonderful presentation. And
thank you, sir.
And ma'am, the points which you have mentioned are more points in the slide. Still, it is there. I can connect with the document and the other slides. Thank you so much. Now, I request Dr. Subhasri, one of the core team member, to propose the vote of thanks and give brief feedback about the system. Over to you, ma'am.
Thank you, Dr. Suresh. Thank you, Dr. Ramya. It was a wonderful presentation. I was there.
You,
I joined little late because of this net issue, but I joined right from the third slide onwards. So
thank you, ma'am.
It was a fantastic presentation. I know your PhD work and how much you are dedicated in your research work. And I've also seen you as an, I was being a colleague of you for a few years in Ethirac. So we know each other, and you did really an amazing presentation today. That was actually an eye-opening research, I should say, that how much important about the physical exercise and as well as the fitness, and how we carry the belief, health beliefs regarding these. It was a wonderful presentation and as well as a contribution for the society itself. Thank you so much for accepting and making it possible. I know it was a continuous sleep and we had it. No, Ramya, thank you so much. And please accept our gratitude from Department of Psychology, American College.
Sure, ma'am. I'm very
And-
glad. I'm really happy, actually. And as ma'am said, we've always shared a lot of camaraderie and a lot of, we have always had like a lot of intellectual discussions as well. And, we have taken a lot of inputs. It's always nice when to connect like this. And thank you so much, ma'am. And I thank the American College, the professors and the head, everybody there. A very profusely sincere thanks from my heart for having me in here.
Thank you. Accept thanks from Medicine of Social Work also.
Yes.
And also the other collaborators and our own viewers, the participants who travels with us right from the April. So you are doing such a, we are doing like a marathon. It is continuously like a relay race going on. So I am thankful to the participants who have been attending and regularly and spreading across the awareness also about the mental health. And they would have definitely been benefited out of this session to know about how health beliefs works on our exercise behavior and how it is important to take care of our health and fitness. Thank you so much.